Welcome everyone. This is Brent Meyer. I am a partner at Husch Blackwell in the Real Estate Development and Construction Business Unit. My practice focuses on construction-related issues, including contract review and litigation. Before we begin and I introduce the panelists, I'd like to cover a few housekeeping items. At the bottom of your audience console are multiple application icons for you to use during the program today. First, if you have any technical difficulty, please refer to the audience technical tips on your screen or click on the help icon at the bottom of the screen. It has a question mark and provides information regarding common technical issues. If you have any questions during the webcast, and we certainly encourage questions from the audience, please submit your question via the question box. We will try to answer all questions during the webcast today, but if a fuller answer is needed or we run out of time, it will be answered later via email. We truly appreciate audience participation and encourage you to submit questions. There is also an icon to assist you with viewing preferences. Please note that you can expand your slide area by clicking on the maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. This program has been approved for continuing legal education in Illinois, Iowa, Missouri, Nebraska, and Tennessee. Wisconsin is pending. To report your hours in Illinois, Nebraska, or Tennessee, click on the CLE widget at the bottom of your screen. You may download the certificate of attendance from the certificate widget. We are excited today to be talking with you about the future of construction and design of healthcare facilities in the wake of the COVID-19 pandemic. We have a great panel today to cover this topic. We are pleased to have Ed Barker with Husch Blackwell, Tawana Hudson at SCL Health, Paul Hughes Cromley at Alterum, Tim Jacoby at Children's Hospital and Medical Center out of Omaha, Nebraska, and Greg Shard at Common Spirit Health on our panel today. Just a little bit more detail about our panelists. After 25 years as a chief legal officer of a multi-state hospital network, Ed Barker has a rare understanding of both healthcare business operations and the U.S. healthcare system's regulatory landscape. He advises clients on matters such as corporate organization, physician acquisition and employment programs, hospital physician integrations, alternative healthcare delivery systems, and finance transactions. Tawana Hudson joined SCL Health in 2007. She was appointed Senior Vice President of Strategy and Business Development, Chief Strategy Officer in 2013, and Executive Vice President, Chief Strategy and Growth Officer in 2018. Tawana leads the development and implementation of SCL Health's strategic plan and identifies and executes strategic and tactical growth initiatives to enhance long-term sustainability of the ministry. Paul Hughes Cromley, for over 35 years, Paul has been involved in healthcare economic and policy analysis, including economic forecasting and health sector economic indicators. Paul leads Alterum's monthly series of timely briefs covering national health spending, employment, prices, and healthcare utilization. We also have Tim Jacoby. Prior to having the wonderful opportunity to be part of the Children's Hospital and Medical Center team, Tim had a tremendously diverse career ranging from working on the recovery of the Space Shuttle Challenger to building the first LEED certified acute care hospital in California. In 2003, Tim went to work for Rady's Children's Hospital in San Diego and spent 10 years at the hospital as the Vice President of Facilities, Design, Construction, Plant Operations, and Maintenance. Tim has also held the same position at the University of Tennessee Medical Center and Children's Hospital in Los Angeles. Finally, we have Greg Shard, Greg is a skilled pharmacy leader with established background in hospital and ambulatory pharmacy operations and leadership. Greg builds and executes business plans to stand up nationwide, automated mail order solution for Common Spirit Health. He also serves as an innovation section chief who served on a response team to obtain and track PPE supplies for Common Spirit Health in the wake of the COVID-19 pandemic. As far as format, I'm going to put up the slide here, but initially we are going to have Paul give a presentation on some of the economic indicators related to the healthcare sector to tee up our Q&A session with the panel. So please let me introduce Paul Hughes Cromley.
Okay, well, thank you very much. It's really a pleasure to be here. And I will advance the slides. I hope that's worked. I called my presentation What's in Store for the U.S. Health Economy, and I'm going to talk about our health sector economic indicators. Let me start by saying that my co-director and I were asked separately, for her by Al Jazeera and me by the Australian Broadcasting Corporation, to come on television and answer a basic question the world was interested in. How can healthcare spending in America be falling in the midst of this pandemic? And of course, I don't have to tell this audience, it's all about discretionary care that was, or elective care that was either directly or indirectly precluded. And that's a big theme of what the health sector is showing right now, that again, in the midst of this unprecedented, and you'll hear me use the word unprecedented quite a bit, in the midst of this unprecedented pandemic, spending and related factors have fallen. Okay, what I'm going to do is I'm going to keep it to about 10 minutes, and I'm going to do three things. I'm going to tell you a little bit about our health sector economic indicators, briefly mention some news items, and then speculate, see what's in the collective crystal ball of my colleagues. Starting off with employment. The background on health sector economic indicators is that about a decade ago, we realized that the main source of information on the health economy came from CMS, and it still does, the official Centers for Medicare and Medicaid Services data, but it's an incredible lag. In December of each year, we get the national data for the previous year. So it's already about a year out of date, and it's only a single data point. So our goal was to come up with a system where we would release reports on a monthly basis, try to bring them way closer to real time. And with spending, which is kind of our central aspect, since it was a healthcare spending dilemma that got us going, we are able to, at the end of each month, report on the previous month. Okay, so that was the genesis of the health sector economic indicators, to produce these timely reports. They come out in three flavors: spending, employment, and prices. They're free on our website. And I'll repeat this in a minute, but Friday, we will get the new spending data, and it's a very big report because it will pertain to April, and it'll pertain to May, and it's critical to see what's happened. I only have spending data today as of April for the nation. But okay, so that's enough of the background. I'm on a slide about employment. I have two of them, and you can see this massive drop, and then a partial recovery, actually a surprising recovery. I think the predictions were that the drop may stay, but as you can see from the slide, we got about 20% of the jobs back, and overall 300,000 new jobs in May to somewhat make up for this massive hole of nearly 1.6 million jobs lost in the previous 2 months. I don't have it here, but for hospitals, we lost 127,000 jobs in April and another 27,000 jobs in May. The story in this kind of a comeback is all on the ambulatory side. There was even an article in the New York Times that we helped produce data for that said, if you want to know what's going on, look at the dentist, because it was dental hiring that was a big part of this. A lot of details there, but I'm going to move on to the sort of biggest picture about jobs, which is that amazingly, as much as the healthcare sector has declined, it hasn't declined as quickly as overall. And we track this each month. It's an item that people are very interested in. What all jobs are from the health sector, and we hit an all-time high. You can see the way that spiked up, and that gray is the unfortunate reality that we are now in after the longest expansion in U.S. history. We are now in another recession, as denoted by the National Bureau of Economic Research. So we are at an all-time high of jobs, percent of jobs in healthcare of the total. All right, on to spending, and you can see, I already joked about unprecedented. Well, let me tell you, that is unprecedented. There's never been, this is year-over-year growth in national health spending, as best as we can estimate it. Again, the official arbiter is CMS, but this is our attempt to emulate it. And you can see this massive decline. Give you just a tiny bit of perspective, we were just on the cusp of national spending at $4 trillion. And here, latest data put us at a little bit under $3 trillion on an annual basis. And again, we'll see Friday what's in store for us. But April had what's in store for May. April had a 24% decline year over year. Some of the specifics: total personal health care was down 30%. Hospital spending, these year over year, was down 41%. Physicians and docs, another down 41%. Dental down 61%. I quipped to my colleagues, I didn't know any dentist that was open, so I was wondering why it wasn't closer to 100%. But they reminded me that it's a big country and not all places are responding the same, of course. Interestingly, drugs were actually up in the month, 5%. Which was down from the previous month, where we think we saw some stockpiling for people who were afraid when was the next time they were going to be able to go out to pick up drugs. Home health was down 33% in the month. Similarly to looking at the percent of jobs or the share of jobs in healthcare compared to all jobs in the economy, there's very big interest in the percent of spending, healthcare spending relative to the entire economy. And this shows that a massive fall from this kind of 18% level that we had been about for years, now all the way down to 15.7%. And the takeaway from this is that as dramatic as the fall in healthcare sector has been, it's not as quickly as the overall economy. So that's what I wanted to say about the indicators. And of course, I'm happy to answer any questions. There's one central takeaway from the data. And I do want to point out that the data will undergo revisions. And in this case, I predict that the revisions will be particularly large because it is such a dramatic experience that we're going through. The data organizations of our government just aren't capable of catching all of this. Not to mention there's all kinds of technical issues about response bias, et cetera. So I do predict some revisions. But the single takeaway is that the single biggest takeaway is that in every previous recession in U.S. history, healthcare has provided a cushion. It's helped to support the non-health economy. And here, it's actually leading. It's actually driving us even lower. So that's again, an unprecedented event. Some news items, and you can see for yourself, and I think these slides will be made available and you can click on them. One that I didn't include because it just came out today is every year the firm PwC comes out with their behind the numbers spending analyses. And they talk to a lot of experts, including people at Altarum. And I didn't have that much time to look at it this morning, but they have decided to have 3 scenarios rather than try to predict what's going to happen. So I think that's a good metaphor for our time, that here's PwC, and they're kind of afraid to say what they think is going to happen. So they teased out 3 scenarios. But these news headlines are about like the ER drop that everybody's familiar with, the fact that outpatient visits are already starting to rebound, various real-time data sources, what's going to happen with M&A activity as we're coming out of this, et cetera. So that's about 10 minutes, and I want to spend 1 or 2 minutes on my crystal ball, which is unfortunately pretty negative. And let me start with the good news, things that you likely know. We're an aging society, which is good if you're providing health care. We love new and shiny things, which is the reason why sometimes even in bad areas and in bad times, you see these nice hospital towers go up. And of course, we love new technology, and nothing like the health sector to adopt that quickly in the US. So that's all kind of a positive story for the near, medium term and longer term for the health sector. The negative story has, in my mind, the following elements. First are payment policies, and these are evolving quickly. It's not quite clear what will happen, and of course there's an election in November, and that will dramatically affect payment policies. But generally speaking, things like site-neutral payment and value-based payment policies are not great for the healthcare sector compared to previous times. I'm particularly concerned with the news today is about this price transparency rule, and I'm concerned that everybody knows these commercial payments, reimbursements are much higher than public payments, and more that's going to get communicated to lay people. And I think that's going to serve to put pressure on hospital and other reimbursements. But more to the specific economic side, I'm negative because we've seen incredible activity by the Federal Reserve, but they're kind of coming to the end of what they can do. There's always more, but they've used a lot of ammo. And we've had this amazing, really totally unexpected behavior by the federal government in terms of stimulus with these 4 acts that I think you could have gotten good odds would ever pass. But now we're starting to see a little bit of reluctance. And in my view, the economy definitely needs more help. And if we don't get it on that fiscal side, I think what we're going to see is somewhat of a cliff with things like support for unemployment insurance, these other payments, and I think that will kind of put us back out, back into more of the trouble instead of what appears to be an improving scenario, especially if you look at things like the stock market. So I want to conclude by saying that I'm concerned about, everybody talks about a second wave of the pandemic. I'm concerned about a second wave of the economy, in that some of the chickens come home to roost when some of these supports fall off. Larger companies are doing the best to kind of hold the status quo for now, but to the extent that their business isn't going to be there in the fall, there will be employment cuts, and those will circle back. And the piece of evidence that I have is that I have a 90-page document that details every aspect, every event during the global financial crisis, i.e. the Great Recession a decade ago. And it's unbelievable to see how many of these events occurred a year or two after the bottom and led to this very slow recovery. So it's hard for me to be optimistic about any of this talk of a V-shaped recovery, et cetera. Anyway, as I said, I'm happy to answer any questions, and thank you so much.
Thanks, Paul. Yes, if there's anybody in the attendance who wants to ask questions, again, there's a Q&A question box that you can type in questions, and then we can circle back to Paul. But I do want to open it up to the Q&A session with the panelists. So a couple of panelists that you guys took off your videos, I just remind you to put those back on and unmute, of course. Given the economic uncertainty that Paul's touched on, are any of you planning on pausing or canceling any planned projects moving forward?
Well, this is Twana Hudson. You know, here in Denver, we are planning to replace 2 facilities that had reached end of life. And we had just completed comprehensive programming for one of those facilities. And we actually have the ability to pause that. We're pausing it for about 8 months, and we'll begin again in the spring. And the thought about that is that we could benefit from any lessons learned from this pandemic, whether it is in the design, air exchanges, whatever it may be. And then should we be anticipating any potential code requirements? So we are not canceling any projects we had in place, but there are a couple that I just mentioned that we're going to delay. And we think that potentially there's an opportunity for lessons learned.
Okay. I got a question for Tim. Tim, you had an ongoing project when this pandemic occurred. Maybe tell the group what the project was and some of the issues that you had to deal with as far as having an ongoing construction site on the property.
Be happy to. At Children's Hospital Medical Center, we're building a new acute care tower, and it's about 430,000 square feet. And we are about a year out from substantial completion. In March, when the pandemic was first hitting, the biggest concern with the labor force was keeping the project going. You're not going to shut it down because people were worried about their jobs. And we were very clear to the team that we were keeping the project moving. Our deadline is important, and we need to keep the workforce going to meet the deadline. And then come about April, as we started getting a few positive cases and the local area started getting some positive cases, the attitude shifted a little bit, and we lost probably half the workforce due to self-imposed quarantines, or the spouse was working and the other spouse that was working on a job site here had to stay home and watch the kids. Or they just weren't comfortable being around a lot of people. So we lost about half the jobs, half of the people. That started recovering about 2 weeks ago. We're back up to normal staffing again on the construction site. And so obviously when you lose that many people, schedule is slipping. And so we're looking at schedule now and what that did. Don't know exactly. We're putting it all there, but there will be some slip to the schedule. The other thing that we've done is added cost to the project because every day we disinfect, the tower plus the IPD spaces. We had to put in some sinks early. Everybody is fully masked, and productivity is not as good when you're masked. When you're masked and you wear glasses, your glasses fog up. Something simple like that on the job site is significant. We've limited access to the job site or ways to access the job site, so everybody is getting their temperature taking. That's just being very precautious and cautious, and actually the team was very pleased with that. So it's costed some money and it's costed some schedule, but we considered it essential to keep the project moving.
Yeah, well, it's good to hear that it's almost back on track, even though you had to deal with some challenges there. For those who are putting the pause on projects and kind of reassessing, and Twana, you talked about this a little bit, but what things are you looking at to make the decision as far as moving forward? What kind of indicators? And Paul, feel free to jump in too if you have thoughts about what you're paying attention to greenlight those projects.
Well, ours isn't based on any financial indicators or volume indicators because, of course, we're replacing a facility that will be smaller, more efficient. So it will benefit the health system, and the patient volume is there. The reason we're pausing is that we know there will be changes in technology, engineering systems based on COVID and this pandemic. We also believe there will be changes to layout and design. So, will we have to really look at what size lobbies and waiting rooms are and how they're designed for the social distancing to be in effect? Do we have to look at high traffic areas? One of the guiding principles in this new facility had been, no grandiose lobbies. And we may have to rethink that to make them larger, more segregated into multiple seating areas. The other thing is we had tried to limit the number of offices we have here. And so we had planned for a number of shared offices. And is that possible if social distancing is still required? Do you limit access points? Do we have barriers for screening, for your financial areas and others, so you have contactless transactions? And there's just a number of areas that I think we'll rethink as we go back and look at the programming again. But hopefully there'll be lessons learned from people that are already in the middle of projects like you just heard that we can benefit from.
We actually paused.
Sorry, go ahead.
We paused several projects, and early on during the pandemic, and we kept the major project going, the Hubbard Center for Children. But some smaller projects, anywhere from $500,000 to $3 or $4 million, we paused, and we were waiting to see for revenue to start recovering fully, elective surgeries to get picked back up all the way to normal, and then the specialist visits starting to return to normal. So once all that returns to normal and the revenue stream gets back to what it was prior to the pandemic, most of our projects will get started back up again.
That's great. And I guess that's a good segue for what Tawana brought up. Is another topic that I wanted to touch on was not necessarily the financial indicators, but how are these facilities going to change? And it sounds like, Tawana, you're kind of taking a pause just to see how that all shapes up over the next 9 months or so. But just talking about the facilities, and I guess for the what things do you need to see change in your facility as far as layout or equipment and things like that?
I just referenced, I think, a couple of hours. When you say technology, one of the things that we realized for a number of our hospitals is that we didn't have cameras in every patient room. So as we started working with COVID patients, we wanted to limit the interaction between the nurses and physicians and other caregivers that would enter the room as much as possible. So we started using iPads as two-way communication, also a way for patients to communicate with their families. But going forward, it really has confirmed for us that we need to have cameras in every patient room so we can use it not only for communication and education, sitters for watching patient falls, but also as a communication vehicle if we have patients in isolation. So that's just one example.
Another example is the mechanical air systems. What is ventilation and filtration changes are going to be seen because of the pandemic. We just happened to make the decision early on that we HEPA filtered our entire new tower, which was great for a pandemic. It relieves some of the issues, but you're going to have more negative pressure rooms. And where does the exhaust go? Do you pay more attention of where that exhaust, where does it leave the building? And do you have more rooms, negative isolation rooms to take care of these type of patients? There is not a consistent message on the best spot to take care of these patients. Is it a negative room or is it a normal ventilated room? There's a little bit of mixed information on that. So you will see I am sure you'll see some difference in the ventilation system and filtration as this moves forward.
We had a question from the group, the audience here. Yeah, I'm just going to read it out here. It looks like, Greg, you flagged it here, but the question's from MJ Torres, who's in the audience. Question for the panelists: do you see the costs being passed on to the customers for the extra precautions being put in place? For example, purchasing extra masks, sanitizing products, extra time for employees to wipe down various areas within the facility.
Happy to respond. This is Twana again. You know, it will really depend on what your reimbursement methodology is. You won't see that, of course, in your Medicaid or Medicare programs. And if you're at risk or you're in case-based reimbursement, that'll just be costs that we absorb as the healthcare provider.
Yeah. Most of the costs that were cited in the question seem to be that they would be absorbed by the hospitals and not passed on.
Especially in the short run.
I thought I heard somebody else jumping in there. Did another panelist want to respond?
Yeah, this is Greg. Some of those noted as PPE, we are able to submit for FEMA dollar reimbursement as far as extra masks, things like that, which we have done in our system. Of course, that's probably years until you actually see a payment for that, but I think there are some mechanisms for ways to recoup some of those dollars.
Yeah. One other thing we talked about when we had our coordination call is I guess the telehealth services becoming more prevalent or more popular or essential, basically. How do you guys foresee facilities dealing with the need for telehealth services?
Well, telehealth was going to happen anyhow, but this greatly accelerated it. And I think hours went up, 300 some odd %. It just soared. And it's been very, very well received by the community and the physicians. As things return back to normal, though, what will be interesting to see is, does that replace normal office visits or does it supplement normal office visits? And how does it, Nebraska has a lot of rural areas. So instead of opening up a clinic in a very small town or having the families drive 2 hours, the telehealth visit can be a godsend because you just get on the computer and go. Now, the problem with that is the bandwidth. Is the infrastructure there to support this in all the areas? Probably not. So, do that.
And where are you guys looking to host these telehealth services? I mean, you got to have some kind of conference room or office space. And do you foresee that being a new consideration for design and building?
Well, for a couple of years, we've actually been building out virtual health consult areas within our physician clinics. We have a standardized footprint for any new clinics that are built. We also have just developed a large call center and have a number of, I wouldn't call them offices, they're smaller than an office, but they are set up actually for mid-level visits to provide virtual health visits and then to refer on to a physician or other services as needed. So it is not something that we do now or that we ever anticipate actually building out additional space within our hospital facilities, not at that cost and at that level of investment. It's something that we have more in an ambulatory environment. Now, mentioning rural facilities, we also operate in Montana, which is very rural, and we do a lot of virtual health, and we'll very likely be using the cameras in the patient rooms for some specialty consults as well. So trying to deal with it directly while the patient is in the hospital. So we're looking at it from an ambulatory as well as an inpatient perspective.
Does anybody have concerns about privacy with the, I guess, the increase in the use of telehealth services? I know we talked about Zoom and some concerns with Zoom, at least from the legal perspective, internally about dealing with clients and having client communications over Zoom. Is that something also that you guys are concerned about?
I think you have to be concerned with it. Matter of fact, I think yesterday or the day before, there was an entire section of the Wall Street Journal that was all about cybersecurity. And so what exactly will be done, I don't know. That's really a technical issue, but it has to be considered, and the appropriate precautions are going to have to be built into the systems.
One of the interesting things is, we always have obligation, whether it's private patient information, anything else that may be confidential. We have obligations for data security, and it's physical and technical barriers. But one of the things that we've really learned from a virtual health or a telehealth component is really making sure that the patient and the physician understand they really have a parallel responsibility for ensuring that there's safeguards in place. I mean, where are you providing the virtual health visit? Where are you accessing it? Because it's really how and where they're seeking the services. Are they a quiet space? Are they in a place where others can hear what's being discussed? So we've had a lot of conversation and education around that piece as well. And we're also discussing, are there other ways that we need to educate or provide more information to those who are actually seeking virtual health visits?
I wanted to throw in that there's no question that the dam is broken on telemedicine and telehealth. In fact, a predecessor company to Altarum, where I work, developed a model for telemedicine 20 years ago because of all the work we did with the military. So from that perspective, it's an old thing. But clearly, this need and the regulatory environment that has been pushed along by CMS has, made this finally become as important as we figured it would be. Question I have is, when I think about a lot of visits that might have led to procedures, but now you're home, and at the margin, I would think that would be a big issue, the extent to which a patient says, well, maybe I don't really need that test, or the physician saying, well, you really do need that test. So I would think that would be a big aspect going forward.
I see that Ed's having a hard time with his microphone. Ed, can you?
Yes, he is.
All right, I didn't mute you, I promise.
No, I'm not taking it personal. I thought it was probably Tawana.
We won't tell who muted you, but somebody.
The one thing for everybody to understand on the privacy issue relative to telemedicine and all of this is that there's a great expansion of telemedicine, which in my opinion is very favorable to the rural, to physician clinics, et cetera. But the Fed has done a number of very interesting things in the last 3 or 4 months based upon the pandemic. One thing, OCR has waived penalties for telemedicine using communication applications that are not considered to be non-public. But don't forget, OCR is part of the federal government. HIPAA is a federal law that does not supersede state law. So unless the states follow, then you have to deal with whether or not the states will allow particular mechanisms, applications, et cetera, to be used and not violate a state privacy issue. Reimbursement, quite frankly, in telemedicine has jumped decades forward from what it was before. And the other thing is that for every telemedicine opportunity, there's usually a state licensing board somewhere in the woodwork coming forward saying, well, you may want to do that particular procedure or consult or whatever, but you are not licensed to provide that level of service. So it's one thing in the privacy world to be aware of. It's changing every day. We have an OCR or a COVID-19 toolkit out on the Husch Blackwell web, which has all kinds of information on it, but also particularly dealing with the telemedicine aspects of COVID-19 and the different state laws on a 50 state survey basis that you can go and scroll and find out a lot of detailed information that would apply to your particular situation.
We had a question come in, and maybe Ed, maybe you can provide some insight. I don't know, it's specific to senior living, but it's a question from Nick Levizorio, I apologize if I mispronounced your last name, Bell Tower. And the question is, what impact, if any, would increasing the use of telehealth or telemedicine in senior living and LTC facilities have on state-mandated staffing ratios? As a construction attorney, I have no idea.
Yes. Well, at least to want to help me, because we had to deal with this in California as basically one of the first, if not the first state to come up with the nursing ratios. You're talking about physical presence on the ratios, and that telemedicine did not compute basically or find you relief on the ratios. So that's the best information that I have.
Yeah.
And quite frankly, some of the ratios and some of the activity associated with getting to the ratios were a mixed bag of whether or not it made clinical sense to do it, or it made employment opportunities and staffing ratios.
Yeah. Yeah, I haven't heard anything more about it. We haven't really engaged in those discussions here yet.
There is also, by the way, if you're interested, and there's a blog posting out on our website that talks about a proposed bill that has bipartisan support, so it's important to look at it, dealing with contact tracing applications and the protocol from a privacy perspective as to how to engage those that you want to trace that may have COVID-19, and whether or not they have to opt in and how they opt out from being traced, and what happens to that information once the issue is resolved or you've gone by the quarantine incubation period relative to the virus.
So
Looks
does
like we
anybody
got
else
another
want to add?
question.
I'm sorry, go ahead, Ed.
Yeah, I think we got I can't see it, Brett, but I think we got another question that just came in. I'm not seeing it. Okay.
You can go ahead and read it if
I may just be behind.
okay. That's all right. For the panelists, any other thoughts on telemedicine or telehealth or in privacy concerns? Otherwise, I'm going to transition to a different topic. Okay. One question that was posed, and it's kind of a contrarian, but I still thought it was an interesting question to at least point out there as a discussion point. Is anyone worried that all the things we talked about, the reevaluating common spaces and the mechanical engineering and the telemedicine, investing a bunch of money on that, and then it being kind of an overreaction? 2 years from now, if we have a vaccine, is it going to be oh, I wish we wouldn't have done that type situation? So I just pose that to the group and kind of see what you have to say as far as the overreaction thought.
Well, from our perspective, that is one of the reasons that we delayed somewhat to see what may be required. I think it was mentioned earlier on the call, there is still a debate on whether it's negative pressure rooms, if it's isolation, what it may be that's most effective. I guess our view, as we've talked about it, is that this pandemic is the one that we are currently experiencing. But I think what it has taught us is that we need to anticipate what may be coming. And if we're building new facilities, how do we best accommodate that without making, when you talk to physicians, they would have the entire hospital be negative pressure as well as our physician clinics. We're probably not going to go, we won't go that far. So we have to determine what is the most appropriate investments to make. And that is one of the biggest reasons we delayed, just to see, or at least we paused to see if there could be lessons learned.
Yeah, that makes a lot of sense.
And Brett, I think on the telemedicine side, it's here to stay. And it's here to stay because Kaiser, for example, has embedded it into their clinical protocols and their delivery system to patients, and it's been very well received by the patients and the clients. And so it's now become somewhat of the norm, and it will be, I think it will be difficult for healthcare to go back. What will be interesting to monitor is how do the managed care organizations fund it? Will they try to go back because they're not sure that they're paying for medically necessary services? So I think the momentum is there. I think the drive is there. The question will be whether the reimbursement is there.
But Ed, back to what I was saying earlier, to the extent that some of those, even if there are excess telemedicine visits in the wash, it may end up forestalling lots of procedures that the managed care organizations don't want to pay for, and unless, of course, they aren't very apparently necessary. So it's not, I don't have an answer there, but it seems like you have a calculus you got to weigh.
Yes, and you're using logic, Paul. And the managed care organizations should see the value benefit of telemedicine, keeping people out of the expensive service profile. And we'll see.
Yeah, and one other topic I wanted to touch on before we wind down, and maybe leave a little room for some questions from the audience. But one thing we talked about, and Dewan kind of made this point just a second ago, is we're dealing with this pandemic, but we need to be prepared for future issues. And how do facilities accommodate the need for, or just hospital systems or healthcare systems, the need for PPE or the personal protective equipment? And I know, Greg, you were heavily involved in that aspect when this came up. So maybe talk about some of the logistic issues and then maybe storage, potential storage issues.
Yeah, so as you mentioned, the PPE needs have really changed. Before, we were really just considering PPE needs for employees, procedural things. Now we're considering the entire environment of care, the entire facility layout, as well as people enter your point of entries. Are we screening? Are we applying PPE then for those in need? So that goes from the environment of care, where you're looking at dividing, spacing out. You mentioned lobbies earlier. Public access points, we've been minimizing those compared to what we had before. And then with the PPE utilization being so much higher, you have increased storage needs, of course. And so that's also led to alternative and innovative uses of PPE or different ways of procuring it. So really vetting those with our supply chain partners and figuring out, is this good enough for our patients, our employees, when we have alternative sourcing needs. So that's really been kind of different. And going down the road, we've gone from just-in-time inventory methods and really having that kind of ability to store just that number of PPE to, going back to that and saying, we need a back stock, we need some to reassess our inventory methods. So a lot of that's changed. And then you have everything from 3D printing out there, alternative materials. So there's lots of things forward and be prepared for something like this to happen again.
I got a question pop up here from MJ Torres, and this is for Greg. Do you see an increase on mail order medicine in the future? There's probably an increase now, but do you see an upward trend continuing, people not wanting to go out to get their prescriptions? I guess kind of the same theory of telemedicine bringing some of the care to somebody rather than having them come to the facilities.
Yeah, and that's been increasing with the entry of places like Amazon purchasing PillPack and and other large employers wanting to get into mail order. It's more efficient. It's a cheaper method. It's more saves healthcare dollars. And then we, just for common spirit, actually, we're standing up a large mail order facility in Omaha here in the next year to serve our 150,000 employees and beneficiaries, and then maybe look into patients. So you've seen everything from free delivery options out there from CVS and Target and everyone else following suit. That's not really sustainable from a retail standpoint, but from a mail order where it's that way, I think that's here to stay, and we'll just continue to expand for maintenance medications.
Any other thoughts on PPE storage? One of the issues that was raised by Tim, who unfortunately had to jump off for a second, is the issue of some of this stuff expires. It's got a shelf life and causes some logistic issues. So I guess that may reduce the need for storage if you're constantly having to turn it over. But as far as accommodating for storage, what have you guys done in the past? What are you looking to do in the future for the PPE need?
Well, there's still challenges with access. We think that'll probably be in place through the end of the year, but we do have plans to have more in stock than we have done in the past. But looking at more of regional hubs where we may locate not only this, but additional equipment as well. So it would be PPE and equipment. We would manage it with our supply chain department, the same inventory management that we do everywhere else, including at our hospitals. But this has really been a lesson learned that we need to have things available so we can distribute it out regionally to the facility that has the greatest demand, rather than it being stored on site at our individual facilities and then needing to move from one location to another.
Hey, Tawana, in a competitive orientation like Denver, do you foresee any opportunity to collaborate with some of your competitors? In other words, why would you all need to be fighting it out for some of these things that you may not ever need to use?
We actually have done that during this last, it seems like it's been a year, but it's only been a few months. The Children's Hospital had a number of extra events, and we're making them available rather than them being allocated out, where there's some discussion at the federal level that they were going to get an inventory and reallocate. And all the health systems came together here in the Front Range, which is a very competitive market. And we were working together on that to move things around. So I think it worked relatively well. It's what you observed is that kind of competition fell to the wayside somewhat, and it was more of a focus on patient care.
Yes. Thank you. Did we lose Brent?
Sorry, I just realized I was on mute. We had a question, a comment come in from MJ, just complimenting Paul on a great question. I think that was a great question as far as pooling resources. I do want to be respectful of people's time and try to get this done before 1 o'clock. But before we wind it down, I think that the telemedical aspect is such a big issue, and it's I think, like Ed said, it's here to stay. That's not something that's going to just be considered an overreaction, but that's definitely the future. So we may push out another webinar on that because it's such a big topic, and the privacy, and there's so many ramifications with that. But I do want to thank the panel for participating. You all provided great insight. Paul, thank you for the presentation on where we are economically. Tawana, Greg, Tim unfortunately had to jump off, and Ed, of course, thank you very much for helping coordinate all this. If anybody in the audience has some follow-up questions, feel free to reach out to myself or, I hate to volunteer the panel, but myself or Ed, and we can get it to the right person. And just to let you know, for those in attendance, if you haven't already, there is a survey icon at the bottom of the screen. So if you would be so kind to complete that survey, it helps us get some feedback about future programs and what's effective and what is not. Also, I didn't tell this to the panelists, but there is a recording of the webcast that can be made available. So sorry if you guys didn't want to be recorded, but I forgot to mention that. I'm sure it's perfectly fine. But thank you, everybody, for your time. Thank you again for the panelists. And yeah, if you have any follow-up questions, please feel free to contact me.
Thank you.
Thank you.